Laura and I are going to have a little bit of a conversation, and we hope that by us chatting together, we'll help to update and refresh you on some of the work that we've been doing. So I'm Kay Stevenson. I'm a consultant physiotherapist and a knowledge mobilisation fellow. So I work at Midlands NHS Partnership Foundation Trust in Staffordshire and at the Impact Accelerator unit at Keele. Laura?
So I'm Laura Campbell. I work in the Impact Accelerator unit at Keele University. I'm project support and knowledge broker, and I support our patients and public members in our community of practice.
And the reason we're doing this over video is because, as you know, with social distancing, we can't meet face to face and we can't have our normal meetings as we normally have them. So we thought it might be quite a nice idea to just have a catch up and a chat. And I'm going to be asking Laura some questions. She's going to be asking me some questions. And hopefully in the process of that, we'll be able to update you where we are. So I'm going to talk to you about moving forwards. So moving forwards, some of you may have seen this document already. It's produced by the NIHR, and it was designed to bring together the very best of research around physiotherapy for patients with musculoskeletal disease, so muscle and joint problems. So in this document, as you can see, if I just flip through it, all fantastic research that has been done in the last 10 years or so, really, about how we can help patients with muscle and joint problems. So it was published back in July 2018. And as you imagine, you know, this could have huge impacts for patient care. So what we wanted to try and do was to get this evidence from a document, a glossy document of about 64 pages, into clinical care. And that posed us kind of a little bit of a challenge in terms of how we were going to do that. So let's talk a little bit about how we started this. And I think one of the strengths of the Impact Accelerator unit, we always try and do things together. So we thought the best way to try and bring this evidence into our clinical practice was to bring together the key people who have got an influence and who manage patients with muscle and joint problems. So we brought together clinicians, commissioners, researchers, managers, and we all came together in a community of practice. Now, I'm going to use this term community of practice a lot through our conversation. And a community of practice, I mean, really is a group of people who come together who have a vested interest, and they come together to try and solve dilemmas, problems, but they co-create and solve the problems that they're faced with together. So that's what I really mean by a community of practice. So we brought together all these fantastic people and we said, okay, how can we get this into clinical care for people in Staffordshire to start with? And we developed what we called a prioritisation framework. So you might think, oh my goodness, what does that mean? Well, what that meant was we developed a couple of questions that we asked all the people that attended when we looked at each individual study in the document. We asked them, is this a clinical priority? Is it a patient priority? And is it a commissioning priority? So we were all able to give some opinion on whether we thought yes or no, it was a clinical priority, patient priority, or a commissioning priority. And we also had some additional questions. You know, was the data to support return on investment? And we all really worked hard on that first meeting to try and drill down an order of priority of the studies that were in this document. So that's where we started. We used this prioritisation framework. It seemed to work well. And by the end of our first meeting, we'd created a list of our top 1 to 20 odd studies.
I think it was a really interesting process, especially with the different dynamics of the commissioners, academics, clinicians, patients and public in one room. So I mean, I don't know what you think, whether it was whether it worked, whether it needed any particular facilitation, and also what were the top 5 prioritised studies that we came up with.
Yeah, and I think we learned some lessons, didn't we, there about how to help people who are not used to being in that environment, certainly our patients, how we could give them some support and assist them to be confident in that environment. But it was really phenomenal, because our patients that attended that meeting were really very clear about what was important to people with muscle and joint problems. And I remember one group, the commissioner sort of saying one thing, and I could see them being influenced by the patient's view. And so it was probably one of those rare things that you witness where, you know, that great interaction between the commissioner and the patient. It was really, really great. And in fact, the commissioner who was involved at the end said, you know, this has been great. Why don't we have something like this, you know, before this point? So I think the process worked, but there may have been some lessons. So if I was to say to you how we might have prepared people better for that, what would be your top tips? If someone was going to go away and do this and they were involving patients and the public, what could you do to help?
Yeah, I think we started off by approaching this as we always have done, with just getting our patient and public members in and sort of trusting the process. But as the document's so detailed and so thick and dense, it was quite overwhelming for them, and not just patients and public. It's quite overwhelming for some clinicians and people as well. So it was trying to all get everybody to communicate that it was okay not to understand something, or it's okay to ask questions, and it's okay to have those conversations. So as we went along with the different meetings, we helped to mentor our patient and public members in particular that was okay, that it was okay to point out these things, and it was okay to ask questions. We found it valuable to support them before a community of practice meeting, and then have a bit of feedback afterwards as well to see how they found it. And as we started to do that, we started to improve how we brought them into things and how we could really get the best out of their voice, because it's so important, and we really wanted to hear it, and we really wanted to give them the platform to speak up. And I think now we have a group of patients in the public who are confident, and they know the document. They're happy to work with academics, clinicians, commissioners, whoever. and yeah, I think it's just communication. It's making sure that we're there for them, and that they can talk amongst themselves and talk to the different groups and not feel that there's any boundaries or silos. So
I think you raise a great point there, that, you know, we all come together to look at this document, and we kind of assume just because you're a clinician, you know the evidence and you know how to appraise it. And I think there was a lesson learned for us around everybody that was in that room, is helping give some support to understand the type of evidence and how confident you can be in the evidence. So we had done some work beforehand, hadn't we, about sort of trying to distill, both for the clinicians and the patients and public who are attending, about trying to distill the research into sort of small summaries, so they were kind of more sound bites. But again, that was challenging to do that, because, you know, phenomenal pieces of work, and you're trying to reduce them to a kind of an understandable sound bite. You asked me about what were the top 5. So through that process, when we judged all the studies using those couple of questions about clinical commissioning and patient priority, and was there any kind of return on investment data. So our top 5 were start back, so stratified care for low back pain, escape pain, so management for chronic knee pain, the BEST trial, which was about group management of patients with back pain, the IMPACT back study, which was an implementation study of the stratified care work that was done in Start Back, and the SWAP trial, which was about vocational advice in GP surgery. So those were our top 5. And there was no surprise really, because those were high quality studies with evidence of clinical effect for patients, but also some financial effect as well, so cost effective. So those are our top 5. So since then, we've really been working, and we've had 5 meetings, 5 community practice meetings where we've been trying to work with clinicians to get this into clinical practice. Some of the important parts of that process have been about project management and making sure we're taking it forward in a logical way, the engagement of the clinicians and patients, coming together regularly as a group and trying to solve those challenges together has been really important.
So as we've just said, our patient and public members have been a core part of our community of practice right from the very beginning of moving forward. So they were great to pick their brains about how accessible and how engaging they found this document, and whether or not they would pick it up and read it and find it useful. And at the beginning, the message we got from them was probably not. So we set about working with the NIHR and the Chartered Society of Physiotherapy to create a public-friendly version. And we wanted to make sure that it was accessible, that it was engaging, that it was colourful, and that it really had the input and the co-creation from our patients and public members. So we've almost finished it now. It's in its final design stages. It's gone from the 62 pages in the full review down to 24 pages. Our patient and public members have told us that they wanted to see patient stories in there, patient quotes, that they wanted further signposting for advice and help. So we've covered all that in there. We've also made sure that it explains that treatment varies from area to area. And really it's just a guide to support people to understand what research is, to understand why they're being treated, why they're getting the treatment they're getting, and that it's evidence-based, and hopefully to equip them with the knowledge to take control of their condition a little bit, and to really try and manage their musculoskeletal health. So we're really excited about that, and our patients and public members have been instrumental and just incredible in getting it to where we've got to now. So brilliant. There were things that they raised that we wouldn't have necessarily have thought about. So how to learn about research and how to learn about these conditions, so that they could, if they wanted to, then go on and read the full review, and if they wanted to, go on to read the research behind it as well. So it's just opening that door to the knowledge for people.
Super. Okay, so if I was to say to you and I, so what has changed because of our work? You know, in terms of what could we say the outputs have been of this, and how has it made a difference for patients? So if I was to think about this, so what, I know in clinical care across Staffordshire, we have clinical services that now utilise the evidence within the document. So they utilise the evidence around stratified care. They utilise the evidence around group treatment for patients with knee pain. So, you know, it has made a tangible difference to what patients are experiencing when they come to their clinicians. And I guess one of the biggest changes, because where we are, we wouldn't be having this conversation if we hadn't got, you know, COVID with us. But one of the pieces of evidence in the document was called PhysioDirect. And PhysioDirect, we are taking elements of the trial to try and help clinicians see patients virtually, so that it creates an electronic record. So we're now starting to use some of the different evidence in this document to help us in this really unusual time that we find ourselves in. I guess the other thing I would say, the so what, is that we've created a real partnership between clinicians and patients and public that we didn't have before, but not around this piece of work. So there is a real commitment, I think, for people to move things forwards and take things on. So there's a couple of things for me to start with. I might think of some more. So Laura, anything that you want to? So what impacts has this had for us?
Yeah, I think working on this together in our community of practice has definitely improved relationships and improved understanding of different groups. So I think commissioners understand where patients are coming from better. Patients understand what commissioners do. I don't think they knew that before, and where they're coming from, and the restrictions and the difficulties they have with commissioning services. And also, you know, with clinicians and academics as well, where everybody's coming at this from a different perspective, and sharing those views has been really valuable.
Yeah.
I think it's also helped shape how we may work in the future. We've learned as we've gone along, haven't we, what a community of practice is, and what works and what doesn't work, what we need to facilitate, what we need to not facilitate, and what we need to let grow organically. So I think that will help us with any other future work as well. And in terms of impact on patients and members of the public, the more this is almost like the final stage of communication, to get that out to clinicians, to then get that to patients. That's what research is all about, isn't it? It's helping the patients, and if we can help even a little bit in facilitating that movement of evidence into clinical care, then I think that's a fabulous impact that we've achieved.
You know, one of the things that this COVID has kind of given us, one of the innovations, is kind of this type of communication, and I think it's going to be interesting for us going forwards how that impacts on those relationships, because we are very much at our core is doing things together, encouraging people, supporting people. And will it make a difference? So do you think doing things virtually for now will make a difference to those relationships? Are we going to have to work harder to make sure we keep people together?
I mean, we're so lucky that we've got this technology, and we've got this way of communicating right now. I think we'd still carry on the relationships, because we've built such a groundwork up so far. I think we've made those connections, but maybe a little bit more of a different way of working, a different hard work of keeping this going. We've got another community of practice coming up in July, where we're doing it virtually. So I guess this is just more learning for us to see how we can strengthen those relationships further, just via video and online. But I think the work we've done with our communication strategy so far, with things like blogs, tweets and things, have helped as well, and that's something we can carry forward. I don't know what you think about the communication side of things. Okay.
I wonder whether just by being able to communicate virtually, we have kept people who have probably been in isolation, who would have, you know, it's allowed them to contribute a lot to projects as we go forwards, rather than losing that sort of side of things. So we've been able to engage clinicians, we've been able to engage our patients and public. Of course, we're people, and so we'll always want to be together in a room. But where we can't do that, you know, I think this technology has helped us to maintain those connections and recognise how important they are. So I think going forwards, you know, we might have a range of ways that we interact with people to keep people engaged. It may be we have our more formalised meetings when we're allowed to, but actually more frequent catch-ups on Teams or something like Google Hangouts, where we can see each other and catch up. But the sense of a community of practice is that doing it together, meeting regularly to co-create solutions together over time. So I'm going to kind of finish by my bit by saying, you know, all the work that the document is online, all our learning we've shared on our learning platform, which I'm sure will appear on a little, we can put something on underneath, it'll appear magically. Anything that you want to ask us about the experience, we're happy to share our experiences. We've got videos, we've got all our presentations, everything that we've done so far, we've tried to share openly, because we've been learning from that. So, and this is part of that learning process. Laura and I having a conversation about where we've got to try and, you know, share where we are. So we'd be very happy to kind of be in touch with anybody who's interested. And if this has been of interest, you know, we can do interviews with other people or chats with other people that have been involved, you know, such as our patient and public, which I think you get a different sense of the experience from them. So I think that's probably next on our thing to try. We're trying something new, and we're just seeing how it goes. So Laura, is anything you'd like to say and add to that?
just I think it's a nice way to catch up with people virtually when we can't necessarily do it now because of circumstances. So it would be great to hear from as many of you as possible, and see how you're coping now, and how you're managing to implement moving forward, or as a patient, how you're perhaps self-managing your own musculoskeletal problems. But yeah, I think moving forward, the beauty of the project is that we've learned all the way through, and we continue to do that, and I'm excited for what comes next.
Just to kind of reassure everybody who's involved in the community of practice, and those people who are perhaps listening to this that aren't involved, that clinicians, academics, patient groups, commissioners are really, really working hard to try and make things as good as they can be given the current scenario. We're trying to use the evidence where we can to improve care. So rest assured that we are still, whilst we're kind of on lockdown, working towards that ambition of improving people's experience. More recently, we've been looking at video consultations to try and make sure we are bringing people in a non-face-to-face environment via video, so that we can start to understand the problem. So we are, all of us in the NHS and in academia, trying to find ways around keeping things moving and taking those innovations forward. So thank you for your time and for listening. I've really enjoyed having a chat to Laura, and I'm sure we will be doing this again with other members of the community of practice. So stay safe, and we'll look forward to chatting to you again soon.